you the highlights of a document that has been put together by both associations, the Heart Rhythm Association and the European Association for PCI. I had the privilege to co-chair it with Dr. Bernard Meyer, who is going to speak here later today. And you have the names of the members on the screen. These are my disclosures. Just to remind you, the scientific documents are not guidelines. The goal is to provide sound advice based on scientific data generated by experts in the field in emerging areas. And this is typically, a typical document deals with topics, novel areas that do not have strong evidence base for good enough for guidelines. Just to remind you that the 2012 ESC guidelines refer to the use of LAA closure in patients who, who have contraindication for long-term oral anticoagulation, and they gave it a 2B class with the level of evidence B. And let me ask you the first question now. That's not the question. Sorry for this. This is not the question. Well, we'll skip this one. So I just wanted to, what I wanted to emphasize in the question that I handed was that the level of, actually there is no level of evidence B for this particular indication. This indication of people who are contraindicated for oral anticoagulants actually is not covered by the PROTECT-AF trial, which is the only randomized controlled trial at that stage. So actually the level of evidence should be no more than C, because these patients were looked at by registries, not by any randomized controlled trials. We're dealing actually with 4 different devices in Europe, but the main 2 that are discussed in the documents are the ACP device, as you know it, and the Watchman device, which has most of the evidence base so far. There are also the Lariat device, more commonly used in the United States because of FDA issues, that is a has a combined endo-epicardial approach for implantation and have the potential of not needing future anticoagulation at all, maybe. And there is this device that is new in the market, the Coherix device by Johnson & Johnson. It's a much shorter device that is implanted more superficial than what we are used to, and we don't have wide clinical data on it yet. There is a chapter on imaging in the document that deals with various methods of imaging. We mentioned that TE is currently the gold standard for imaging, and there are potential alternatives which you will hear about later today, the CT, the MRI, and the ICE. The preoperative imaging should concentrate on excluding the LAA thrombus, and measuring the LAA in several angles, and demonstrate limitations on the use of particular devices. Those who deal with this know that if the length is shorter than the width, you cannot use a Watchman device. If the appendage is very large, you may want to use the Watchman. If it's very small, you may want to use the Amplatzer, but this is a kind of a moving target that changes with technology. Imaging during the procedure, you use the TE for most places use TE for the transeptal puncture at a relatively posterior area. You use it for the location of the device concomitant with the fluoro. You use it to exclude leak following positioning of the device and to watch for complications. Imaging following the procedure in patients who are implanted with the Watchman device and follow the Watchman protocol, the PROTECT-AF protocol, we recommended the TE at 6 weeks before you stop the Coumadin, at 6 months before you stop the dual antiplatelet therapy, and at 1 year, and maybe annually thereafter, but we are not sure that it adds a lot. Regarding the ACP device, data is based on registries, and most of them had one TE somewhere between 1 to 6 months, depending on the protocol of treatment. It makes sense to do a TE before you stop one of the components of the dual antiplatelet therapy. The purpose of the imaging following the procedure is to verify no leak, and the number that was adopted is 5 millimeters, although it's not very well based. It is used to exclude thrombus before you change anticoagulation therapy to ensure no dislodgement and to guide future anticoagulation. There's a chapter dealing with standards and requirements. These are the standards about the operators. An operator acquainted with transeptal techniques and with LAA anatomy, whether it's an interventional cardiologist or electrophysiologist. There should be, and very important, to have an experienced echocardiographer. It's not only that he has to be experienced, but he has to be experienced with this particular procedure. All of you are well aware of very experienced echocardiographers who cannot help you in these procedures because they're not familiar with the fine details. The operators should have experience with pericardiocentesis. We had discussion whether surgical backup is needed on site, and we came to the conclusion based on the fact that some of the most active centers with LAA occlusion do not have surgical backup, that experience with cardiocentesis and surgical backup within 1 hour is a reasonable requirement. Regarding training, we thought that operators must go theoretical course that is usually provided now online, should attend live cases in training hospitals or online, and should be proctored for several cases at home with his or her own team. We thought the simulator training that is becoming more and more abundant is very helpful, but should not replace attendance at real cases. We set some standards for data collection and registries. We thought that it's very important to have registries in this area of which is a kind of a moving target. We thought, and these are the main elements that were listed for such data collection and registries. And I know of several places that already started this kind of registries, including in my country. There are some demographic data, history, some technical data on the implantation, size, type of device, number of attempts, complications, the antithrombotic treatment and discharge, and some limited follow-up data. I'm not going to go through, there is a chapter on the evidence on which the recommendations are based. I'm not going to go through this because you heard a lot about it already and you will hear later today. So we have several studies that support the use of the Watchman device and describe the results. As you heard, 2 of them are randomized controlled trials. 1 of them is published, the other is not published yet, the Prevail. And there's a whole list of registry type studies, and not including the one just mentioned by Dr. Tsikas, that support and describe the results with the ACP device. The results are very similar between the 2 devices, with some, I should say, what seems like a better technical success with the ACP, somewhat better technical success, and somewhat decreased risk of leakage. But you know, this is comparison across trials, and I don't know what it means. We discussed the issue, as you know, the PROTECT-AF trial and the various Watchman trials looked at Watchman as compared to Coumadin. We don't actually have any comparison to novel anticoagulants. We don't have any comparative data. But we know that some of the novel anticoagulants, such as the low-dose dabigatran and the apixaban, are expected to have lower risk of bleeding than warfarin, and that apixaban may even be equal to aspirin, which is given anyway nowadays with any left atrial occlusion device, and that some of the novel anticoagulants, such as the high-dose dabigatran and apixaban, are more effective than warfarin in preventing stroke. So the bottom line is that one cannot assume non-inferiority or superiority of LAO over novel anticoagulants based on warfarin, because the results with novel anticoagulants are expected to be better. So we're not sure that you can actually extrapolate from warfarin to novel anticoagulants. And as you know, the use of novel anticoagulants is supported by a much wider base of evidence than the use of left atrial occlusion. So let me ask you a question. Which patients do you primarily implant or refer to LAAO therapy? Patients with a history of bleeding on anticoagulants, patients with previous stroke on novel anticoagulants, elderly with recurrent falls, or patient request. What makes the majority of your patients at home? Please vote now. Can we see the results? Okay, the vast majority implant LAA occluders for history of bleeding, and this is also what exists in most of the registries and that of contemporary practice. What do you think, in your practice, is the best treatment for a patient who refuses Coumadin? He heard about what happened to his friend, someone bled on Coumadin, he doesn't want to do all the blood tests, he refuses to take Coumadin. He has a CHA2DS2-VASc of 3 or 4. What's the best option for him? Dual antiplatelet, novel anticoagulants, LAA occluder, or aspirin only? Please vote. Can we see the results? Okay, so the majority vote for novel anticoagulants, and I agree. So let's see how we put together the various recommendations regarding current indications for LAA occluder in patients with atrial fibrillation with relatively high risk, and it can be either CHA2DS2-VASc above 2, equal or above 2, or CHADS equal or above 1. The basic principles are that oral anticoagulants are still the first-line therapy with preference to novel anticoagulants according to the guidelines. You should use LAO when there is contraindication to any anticoagulation, but not to short-term antiaggregants. And when there is excessive risk of anticoagulation, but no definite contraindication, you should prefer NOACs. But if you feel that it's contraindicated or risky, consider LAO. And if a patient refuses vitamin K antagonist, advise NOACs, but if patient refuses, suggest LAO. It's a legitimate proposal in view of the PROTECT-AF trial. This chart was put together by Dr. Lee Walter, who was part of the committee that put together this document that deals with patients who need anticoagulation for high risk for moderate or high risk for thromboembolism, and they form 4 different groups. One group is the group of patients who are suitable for oral anticoagulation. Of course, they should be put on oral anticoagulation with preference for new anticoagulants. Patients who have definite contraindication for any oral anticoagulation, patients who bled, had cerebral bleeding, they should be offered LAA occlusion provided that they can get at least a few weeks of dual antiplatelet therapy and lifelong single antiplatelet therapy, at least according to current practice. There's this group of patients refusing oral anticoagulation. After receiving adequate information, we recommend to advise them to use novel anticoagulants. Patient agrees, that's fine. If patient disagrees, we can discuss LAA occlusion with him or her. And there's this group, less well-defined, of increased risk for bleeding. Patients with HAS-BLED score of 3 or more. Patients with need for prolonged triple anticoagulation therapy, such as those who get repeated stenting. Patients with increased bleeding that is not well-defined under the HAS-BLED score. We heard about different bleeding scores. Patients with thrombocytopenia, patients with cancer, patients with severe chronic renal failure or renal disease. In these patients, you should make some kind of an individual risk-benefit calculation. If you feel that they are okay for anticoagulation, that is fine. Otherwise, they should get LAA occlusion devices. We mentioned that there is no evidence today to support LAO as an adjunct to oral anticoagulants. For example, we saw in Dr. Tsika's presentation that some cases were implanted for stroke on Coumadin. If it's on adequate dose of Coumadin with appropriate INR, we're not sure that there is any evidence to support this approach. And also, there is no evidence to support LAA occlusion as an adjunct to AFib ablation, other than in clinical trials that are currently run. Regarding anticoagulation, we looked at 3 different groups. This is the group of patients who receive Watchman, who are at low risk for bleeding. This more or less follows the PROTECT AF approach. You give IV heparin prior to or immediately after transeptal puncture. A patient gets aspirin load prior to the procedure if he is not already on aspirin, and continues indefinitely. Following the procedure, several hours after the procedure, patient is started on low molecular weight heparin until Coumadin catches up. Coumadin is started after the procedure with target INR of 2 to 3 until 6 weeks after the implantation, where a TE is performed, and if there is no leak, Coumadin is stopped. Otherwise, you continue until the leak closes. Once you stop Coumadin at 6 weeks or later, you start Plavix up to 6 months, and then at 6 months, you leave the patient on aspirin only lifelong. Some people already perform the procedure on Coumadin, as we do with AFib ablation, but these are not the majority. The second group that you discussed are the patients who receive a Watchman device with relatively high bleeding risk. There are some differences. We treat with IV heparin similarly. We give aspirin load. Initially, we give Plavix load. We don't give any Coumadin to these patients. And we give the Plavix with aspirin for any time between 1 to 6 months, depending on the individual risk. And then the patient is left on aspirin only. As the risk goes up, we give Plavix for shorter and shorter period of time, going down to 1 month in some centers and in some patients. This is the protocol for ACP device, IV heparin, same, no warfarin, no low molecular weight heparin, aspirin and Plavix load before the procedure. Aspirin is given lifelong. Plavix is given for anywhere between 1 to 6 months, depending on the risk. And in some cases that cannot receive aspirin, Plavix is given alone. There's need for future research in the area of randomized controlled trial for the ACP, which we don't have any randomized controlled evidence yet. We need, of course, randomized controlled trials in high-risk population that cannot receive anticoagulants as opposed to the PROTECT AF population. We need a randomized controlled trial of LAOs versus NOACs rather than versus vitamin K antagonists. And of course, future devices are in the pipeline, and we will have to learn them, as well as the various epicardial approaches. Thank you very much.